good afternoon, everyone, depending on where you live. I am grateful to work, live, and raise my family on the unceded traditional territories of the Coast Salish peoples, including the territories of the Musqueam, Tsleil-Waututh, and Squamish nations. Welcome to Genome BC's Data Literacy webinar series. Starting on September 21st, we will have a few webinars focused on artificial intelligence. We will begin with a presentation detailing the Pan-Canadian Artificial Intelligence Strategy featuring Bo Wang from the Vector Institute. We will continue through the fall and early winter with presentations by experts in machine learning and natural language processing. Today's presentation is part of another mini-series we started last month on Pan-Canadian strategies. It is my pleasure to introduce our speaker, Dr. Kim McGrail, who has been a pioneer in our province in setting up a secure data sharing, data linkage, and data analytics platform for healthcare, health services, and population health data. She has started Population Data BC and has been championing responsible data sharing for decades now. A few years ago, she started to work on a national equivalent of this initiative, and she will tell us a bit about that in her presentation. She was also part of the expert advisory group that the federal government had convened to advise them on the Pan-Canadian Health Data Strategy. Kim, we're looking forward to hearing about what the group has recommended.
Great. Thanks so much for that introduction, Zsuzsa, and for the opportunity to be here. It's really great to be part of the series. I have a lot I want to get through today. We will definitely leave some time for questions and answers. So some things I'll touch lightly on. We can pick them up in that phase of the hour, if that works. So I am going to be talking about the Pan-Canadian Health Data Strategy and a little bit of an introduction to Health Data Research Network Canada, which is this a collaboration that's trying to support the multi-regional research across the country. And just to add to Zsuzsa's land acknowledgement, I also am speaking to you today from the traditional unceded territories of the Coast Salish peoples, the Musqueam, Squamish, and Tsleil-Waututh nations. And the work of that I'm involved in really spans lands and peoples across the country. So here's an outline for what I'm going to be talking about, and grateful to CIHR for the funding that they provide to Health Data Research Network Canada. And maybe I should also just say for introduction of myself that I'm a professor in the School of Population and Public Health at UBC and was trained at the, I just describe as the intersection of health services and policy research, health economics, and population health. And the fact that data were such an important part of the research that I do, because I'm a quantitative health researcher, and this is part of the reason that I got drawn into the space of thinking about data as science infrastructure and trying to make data available to other people, and particularly in that context of large scale, linked, routinely collected data, in many cases combined with researcher collected information and so on. So just to get right into things, I'll start with some bits on the Pan-Canadian Health Data Strategy and the Health Data Charter. So I think probably for the people who are here today, it's not a surprise, these kind of headlines that came out in the early part of the pandemic, noting that we were having a problem with data in Canada, and particularly with data sharing across the country to support all of the modeling and understanding of data that was needed to be able to manage and respond to the pandemic. So this sparked a lot of conversations, of course, that went into race-based data, the data that we weren't collecting, the data that we needed to collect and organize better, the data that we needed to share across boundaries, that sort of thing. It also prompted the Public Health Agency of Canada to really think about the need for trying to restart the idea of a Pan-Canadian health data strategy. So by the end of 2020, they had made those plans and actually then put an expert advisory group in place. And as Zsuzsa said, I was very fortunate to be asked to be part of that group. So we started meeting in December of 2020, and we worked together through August of 2022. Some of us are still carrying on, well, many of us are still carrying on working together, but I'll come to that a little bit later. Formally, we disbanded in August 2022. Our mandate during that time was not to write a pan-Canadian health data strategy. That was always going to remain the responsibility of Health Canada working with provinces and territories, but we were to provide advice that would help them with the development of that strategy. And the group included experts from across the country that really did have quite a range of expertise. It included clinicians, people working in the AI space, people with a background in law. Many of you will know Bartha Knopper. She was one of the people involved. People who work in provinces and territories, privacy commissioners, health services researchers, and other kinds of researchers, and members of the public. So it really, and we didn't always agree. And I think even at the end, we didn't necessarily always agree on absolutely everything, but to my mind, that makes for a good group and a lot of really frank and encouraging discussions about how we could, even in the context of not necessarily always agreeing on absolutely everything, come to some recommendations that would help us move forward collectively. The expert advisory group was chaired by Dr. Vivek Goel, who is a public health physician and also has had lots of senior leadership roles, including at the University of Toronto and now as president of the University of Waterloo. So he was really quite an impressive chair for all of this, still remains very, very committed and active in trying to advance what we put forward to the expert advisory group, and was supported, all of us were supported by an excellent secretariat that was located at the Public Health Agency. So I'm not going to go through all of the 3 reports that we put together as an expert advisory group, but there were 3. And the reason there were 3 is that the first report really, we wanted to review things and just be conscious of the fact that we've been having conversations similar to this for the last 60 years and have not necessarily made as much progress as we would like. So there was a necessity to kind of look back and see how we were going to be able to do something different this time that actually might have more of an impact than the previous tries in this area. The second report then really talked about the foundation of things that we need to be able to move a strategy and actual change in the health data landscape forward. And then the third report was this idea of working toward a world-class health data system and a series of recommendations that were put together. They're all relatively short reports, I think very easy to read. So when slides are available, those links are there, but it's pretty easy to find them. If you just search on Expert Advisory Group Pan-Canadian Health Data Strategy, you'll find your way to the Health Canada site where these are loaded. Again, this is probably not news to anybody on this call, but I think just so we all have a kind of common view of things, this idea of the current state where there's systemic barriers to sharing data. So we collect data, and this figure focuses on the healthcare system context, and we were talking about health data a little bit more broadly than that. But the idea that we collect data in the research context, in primary care, in lab and imaging, and all of these other places, and those are often in and of themselves relatively well-developed health data systems, although many of them also still have some holes and issues. But even more fundamentally, it's really hard to cross those data systems seamlessly. And whether we're talking about the provision of clinical care, the use for health system management, or use for research and innovation, there are just some barriers in being able to combine and use all of these data sets together. We've made some progress in this, but not as much as we need to make. And one of the consequences, of course, is this idea of binder medicine, where we still expect, or in some sense, require patients and family members to keep physical hard copies of health histories and so on, and carry those around to make sure that people who are providing care have all the information that they need. It's also results in this circuitous pathway if we actually want to bring different data sets together for other kinds of uses as well, or more problematically, maybe there isn't a clear pathway at all for being able to access the data that we need. So thinking across all of those different levels, from everything, again, from individual clinical care all the way up to research and innovation at the broadest level, these are the things that we identified as being the foundations for a good, well-functioning health data system. And that is working from the bottom up, data interoperability and architecture, clear and accountable data governance, effective and equitable data policies, and public trust and data literacy. I'm just going to really quickly identify that when we talk about data literacy, that's not just public data literacy, it's data literacy for everybody involved in the health system, which means fundamentally everybody, though maybe a different kind of data literacy for different roles. I think there's lots of improvement that can be made in all of these. But these are the foundational building blocks and necessities if we want to have a solid health data system. So I'm now going to turn to the specific recommendations from the third report, and that's going to be very related to the health data charter. So the first recommendation in that third report really is this kind of foundational piece, and which is the vision, if you want, the North Star kind of orientation, which is a commitment that by 2030, all people living in Canada will benefit from a fully integrated and continuously optimized learning health system. And that would be guided by principles of the Canadian Health Data Charter, which we then ended up referring to as a health data charter rather than Canadian one, because I think we all believe that the precepts in the charter, which I'll show you in a minute, are universal in many ways. So this idea that if we want a learning health system, one of the fundamental pieces in that is data, but ultimately it's not data for data's sake, it's data so that we can actually provide people with the opportunity to be healthy, to and function in society and make the choices they want, because health is not necessarily something that's getting in their way. And the learning health system is a way that we can get to do that. The second recommendation in the report is that jurisdictions demonstrate support for First Nations, Inuit, and Métis Nation data sovereignty, and that be a distinctions-based approach. So this is just it's a second recommendation for a very clear reason that we really need to honor the United Nations Declaration on Rights of Indigenous Peoples. This is enshrined in legislation at the federal level in Canada and in BC in our DRIPA legislation as well. And a few other provinces are moving in that direction for provincial legislation to align with the federal and UNDRIP. So this is an important precept. It underlines everything, and just I'm going to make some assumptions that that's there throughout the rest of the presentation, but it is really, really important that we truly get to this nation-to-nation relationship and support Indigenous data sovereignty. For the rest of the recommendations, I'm actually going to run through the Health Data Charter. There are 10 recommendations in the third report, but they really fundamentally align with what we put in the charter. And so I want to actually go through that so you see what the charter is all about. And this really, it comes from this idea, a couple of things. One is that there's a right to participation in science and research that has been kind of core to a lot of the genomics-based thinking. And again, this comes from Bartha and others in that space. But the other is that we really wanted to write a charter that would be complementary to the 5 basic principles in the Canada Health Act. So something that would be relatively simple for people to understand, but that really lays out not the how of how we're going to get from where we are now to where we need to be, but the things that we could all agree on so that we can work on these things collectively. So first thing in the Health Data Charter is that we really need all of our design around health data systems to really put people at the center. So this is to ensure that data follow the individual, and this is for clinical use, for analytic access, but also for personal use by patients, by family members, and so on. So if we don't have person-centered health data in the near future, or at least as that longer term vision, I think fundamentally we will have failed. And this is a bit tricky because we also need to redesign our delivery systems so they're person-centered. And but I think in lockstep, if we think maybe if we design health data systems that will help with the delivery systems to produce what they're wanting to do and vice versa. The second part of the Health Data Charter is that we need common standards for terminology, for health data design, for stewardship, for interoperability, for access, for portability. So these common standards really are not just about the kind of standards you might think about coming from InfoWay, like the technical pieces, but they're also standards that could come from CIHI, that could come from provinces and territories and so on. I'll speak a little bit to the stewardship. So the common standard for health data stewardship, which we talked quite a lot about trying to move from a custodial model of health data protection, which is protect data at all costs. And the easiest thing to do in that, because if you're really like super focused on the custodial aspect of things, is to lock the data up and not to let them be used, because that feels like it's how we reduce the risks of things happening badly in the data space. The challenge with that is that it doesn't really speak to the counterfactual of the bad things that happen when we don't use data to actually try to improve systems and find where things are not going as well as they should. So the idea of stewardship in this space is that we have a responsibility to protect the data, of course, but we also have a responsibility to use them for public good, for benefit of individuals, families, communities, societies, and so on. The other piece I'll pick up here is the interoperability, which you could think about this coming from a very technical sort of standpoint, but we really talked a lot about the human interoperability space in here too. There's so many people who are involved in health data stewardship and health data production and health data use. And we really need to have interoperability at that person level, which really, I think in many ways resolves down to trust and faith and common sort of sense of what we're trying to do and how we're trying to do it. The third part of the health data charter is that we need to have, of course, quality, security, and privacy of all health data. And that is both to maximize benefit and reduce harm, both to individuals and to populations. I'll just say here, I think a lot of time we really focus on the sort of individual level autonomy and in all of this, but health data and all other data really have a relational kind of embeddedness in them too, which I think people in the genomic space really understand, because genomics, of course, can tell you something about individuals, but also family and community members in many cases as well. So we really need to think about that combination of maximizing benefits and reducing harms. The fourth principle is that we want to ensure that there's timely accessibility of health data. And again, this is to individuals, to decision makers, to clinicians, to researchers, the health workforce more generally, all of that. The use of data, we want to make sure that it's available and actually used to develop policies, programs, services, statistics, research, and that all of that needs to be for the public good. And in alignment with the ideas of open science, so that we're very transparent in how we're using data, and that we're setting things up so that we can have reproducibility and replicability in that space as well. There's another principle for alongside that really flows from that use of data, as I described for public good above. We do also want to make sure that we have data that are available for social and technological innovation. And that absolutely can be in partnership with the private sector. This is aligned with the idea of value creation, international best practices, and so on. And I would hasten to say, of course, there still needs to be public good. The international sort of public expectations around this, based on deliberations and other things that have been done, is that absolutely the public accepts and supports the idea that private sector and private sector, public sector partnerships are really, really important to advance things like development of new drugs and tests and biological markers and all of those kinds of things. But there needs to be public benefit as well as any sort of private sector benefit as well on that. I've already talked a little bit of health data literacy. This is for the public, for clinicians, for decision makers, for the health workforce, and I would say for researchers as well. We need to increase our data literacy, particularly as we think through some of the conversations that happened during COVID about race-based data and equity and commitment to that, as well as the indigenous data sovereignty piece. We need to have harmonization of health data, governance, evaluation, and policy. So this is not to suggest that we're going to have the exact same legislation in all of our provinces and territories, but at least if we have something that understands where those are harmonized and trying to then harmonize some of the governance that comes out of that, it just will make for smoother operations and the ability to do more with less friction. Again, here in the Health Data Charter, we make that statement of the support for First Nations, Inuit, Métis Nation data sovereignty. And then the last principle of the Health Data Charter is wraps right back around to that idea of being person-centered. And with the purpose here is that we need to have inclusion of diverse members of the public, patients and communities and other stakeholders in our health information system development and oversight. In other words, there needs to be ongoing input into governance and allowances for use of data, what's appropriate, where we want to actually move things forward, where we might need to pause and think a little bit through before we push into some uncharted territories. So that's all of the Health Data Charter. Now I can tell you, I already mentioned that we disbanded as the expert advisory group in August of last year. But there's been a lot of action since then outside of the expert advisory group, well, and alongside what we were doing. So this is just a little bit of a notion of the pathway to implementation of the Pan-Canadian Health Data Strategy. The actual strategy is, of course, as opposed to the advice that we provided through that group. So they actually, in Health Canada, Public Health Agency, and then working with provinces and territories, in parallel to our work in the EAG, they put together a time-limited task group to actually start talking about what was coming out from our advice, their own kind of input into that, and then them thinking about implementation. So that was put together in 2020. And implementation planning got pretty serious in 2021 with, again, working through the provinces and territories and thinking about the operational steps that would need to come out from any Pan-Canadian Health Data Strategy. There was a roadmap for implementation that was started in 2022, and this was Health Canada and Public Health Agency of Canada working with provinces and territories, and then asking CIHI, Canadian Institute for Health Information, to start developing a roadmap for implementation. And that was put together and discussed with federal tables. And then in February of 2023, there was the budget announcement, both of some additional funding that was flowing directly to provinces and territories, and some, for the first time, indicators that actually relate to health data, as in, for example, the proportion of members of the public who actually have access to health data systems and the viewing of their own health data. But there was also, separate from that, a $505 million set aside over 5 years, so it's $101 million a year, for CIHI, for Canada Health Info, and for other health data partners to start advancing some of the precepts that were put forward in the Pan-Canadian Health Data Strategy. So lots of work to be done still, but some positive kind of developments that have happened over the last while. And I suspect, this is just a personal editorial viewpoint, I suspect that there may be more coming in the upcoming budget on thinking about implementation of all of these things. In addition to those very structured federal, provincial, territorial interactions and planning, and again, this is just my view as Kim McGrail. This is not a formal view from anybody else, although I think there's some agreement with, well, a lot of agreement with my fellow expert advisory group members, is this idea that real progress on this is going to depend on far more stakeholders than the provincial territorial ministries of health working with Health Canada and Public Health Agency. Not to say at all that those are not important. Those are incredibly important parts of how we push things forward. But we need to think about a much broader group of stakeholders, including the public and charities and public sector organizations, private sector, researchers, rights holders, and all sorts of other interests working together. So if we can actually all be rowing in the same direction, then we're going to have some chance of getting somewhere. So we need to actually try to find a way to build coalitions and to do that work together. We need to think about building the future, as in thinking about interoperability standards and putting those technical capabilities in place. But we also, of course, have to work with what we have now. And because I think, a lot of what we're talking about is a 10, 15, 20-year pathway to get to a much, much better interoperable system. But we can't really wait that long to make things better. So we've got to, the old adage about building the plane while we're flying it. So we absolutely have to think about how we can actually use the systems we have now to create more ability and smoother access to data and use of data and all of that sort of stuff. we really see aligning all of this work with the health data charter as key. And again, not because the data charter, the charter is telling us exactly what to do or how to do it, but it's a common destination, a common set of principles. And if we all can think about choosing tactics and projects and initiatives that align with one or more of the principles in the health data charter, then I think that we will collectively be moving together and putting this big giant puzzle piece together in some way. And there's going to be more coming, I think, on, I hope, on how to actually align ourselves with the charter, signing on to the charter, and creating that sort of collective work together. So I watch this space, and we're trying to work on how we actually formally, or at least transparently, build that coalition. Okay, now I want to take just a few minutes to talk about Health Data Research Network Canada and our objectives and actions, and particularly how these align, in my view, with the Pan-Canadian Health Data Strategy. So I'm sure most of you maybe don't know what Health Data Research Network Canada is. We are a network of organizations that are listed here across the country. We include organizations that within provinces, territories, or Pan-Canadian that have or hold and can make available data for research purposes, and ideally in some cases for other purposes as well. So these are data centers like Population Data BC, ICES in Ontario, the Canadian Institute for Health Information. And then there's also other organizations that are working on things that are relevant to that space. For example, GRI in Quebec is working on technical solutions that will help us with some efficiencies and working together and all of these things. So all of these member organizations have come together. We have been funded by CIHR under the SPORE, the Strategy for Patient-Oriented Research umbrella, to work together to help support multi-regional research. We've been working together informally for a number of years, but now formally with funding for a little, less than 4 years now. Our vision as Health Data Research Network Canada is that data across Canada will drive improvements in health and health equity. That is a vision that is much bigger than we recognize we can achieve on our own. In fact, we wrote that vision specifically that as a much bigger ambition because we recognize and accept and embrace that Health Data Research Network Canada needs to work with other organizations to achieve what we want to achieve. We're not trying to be all things to all people or solve all problems ourselves. We're really wanting to fit into the system as it is and to fill in some gaps that we identified that were there, particularly the gap of being able to do really good pan-Canadian and or multi-regional, multi-jurisdictional research. So our mission to achieve the piece that we can really push forward is to bring people and organizations together from across the country and to support transformative and world-leading health data use. So we don't have a research agenda ourselves within HDR in Canada. We're very much about supporting researchers, making things possible that have yet to be possible today, and letting researchers and providing services that researchers can spend more time actually doing the research that they want to, and the more ambitious aspects of that. So we have 5 objectives. I'm just going to run really quickly through each of those and how we're responding and providing things that we are hoping and believe will help for this. So the first of those objectives is developing and improving services and supports for data access. So just to give you some examples of this, we have developed a data asset inventory and an algorithm inventory. So the data assets are all of the assets from across the country that are available through one or more of our HDRN member organizations. And we have more than 550 data sets that are listed in that data asset inventory. And just for point of reference, there's about 370 of those that are not available either through Statistics Canada or the Canadian Institute for Health Information, both of whom you will have seen from the previous slides are members of our network. But just to say that there's lots and lots of data in the provinces and territories that do not exist at that pan-Canadian level, but do exist in perhaps more than one province or territory. The algorithm library has about 175 algorithms in it, and those are things that have been validated for use so that we know that we have apples to apples comparison in, for example, case definitions for chronic disease is one of the big things that's in the algorithm inventory. These are things that are drawn from the peer-reviewed literature, so they have gone through peer review and have a sense of quality. So these are, you can use these things with confidence is what I'm trying to say. We've also done a privacy legislation review from across the country, and specifically focused on routinely collected data and the kinds of things we can do where data can or can't move across jurisdictions and so on. And based on that, we've provided some guidance for people who are wanting to collect your own data through research projects. If you want to be able to link those data to routinely collected data, there's consent-based information that shows you how to write that consent so that the data linkage will be possible, and encourage people, particularly if you're collecting your own data or running a trial or something like that, encourage that data linkage aspect of things. This is particularly encouraging because now with the Tri-Council policy statement, enabling broad consent for data linkage, this is a really big opportunity to think about the ability to do longer term follow-up and that sort of thing with data over time. All of these things are available on our website. And in addition to that, if you, one of the other things we've been working on with the Data Access Support Hub, which is our the portal through which you would get access to services through HDR in Canada, is we've done a policy review of the way data access processes work across the country, have made that into a clearly definable process step, which again, you can look at on our website. But then we've also created the services then to support people in going through those processes in multiple jurisdictions. So if you come to the Data Access Support Hub and you can put in a question, we can help you understand feasibility of your project or to find the provinces or territories that can support your research, or if what you're proposing can be actually supported by services and data available through CI-HI or Statistics Canada, then we would of course direct you there. We work with a no wrong door policy. We'll direct you to the service that can actually help support the research you're trying to do. This comes with submitting an intake form. We would organize a meeting and so on. We can provide feasibility letters and estimates of cost for any submission to grant applications. And then when you're ready to make a data access request, we actually have just in the last couple of months put together a process where you have if you're requesting data from 3 or 4 or 5 different provinces or territories, there's one data request that you put in through us, and then we shepherd that work behind the scenes. So we have not, at this point, we do not have one process in all of our jurisdictions across Canada, but we're trying to manage it so that researchers who are making requests have only one process, one place to go, one relationship to negotiate and so on. So even though this will still take some time to get data together, it will take less of your time and less of your research budget, much less of your research budget to get things, these things done. I'm also gonna really quickly say that we are not at this point promising at all that you are gonna be able to put all of your data into one location. I think you can imagine that that is not allowed by most provinces, particularly for non-consented data. But we are working on a lot of things that will make the analysis of the data in multiple locations easier. So, and I'll get to that in just a minute. So diversifying and harmonizing data and supporting innovative and privacy sensitive data use is a second objective that we have. And this goes right to what I was speaking about before. If we're going to do multi-regional research, at some point you need to get to a place where you've got, whether it's a common protocol that you're using or perhaps a common data model that you've developed, an analytic data set that is tuned so it's equivalent across the country. We've been working on a pilot project to develop the ability to provide researchers with a common data model. And we've been working with both the CNODES group to look at their common data model. This is a Canadian network on observational drug effect studies. So that's very much tuned to the kinds of data that people working in that pharma or drug effectiveness space would need. We've also been looking at OMOP, which is supported by the Odyssey group. So this is something we're looking at both because if we could get an OMOP common data model in place, and Canada that would help with multi-regional research in Canada, but it also would really set us up well for being able to do international collaborations. And so the idea with this pilot project that we've been working on is just to try to look at the benefits, cost, user acceptance, research demand for this sort of thing, how much resource it would take to put in place. But we also really worked hard on trying to figure out how we could create a system so we're not tied to just one common data model, because we know, first of all, that one common data model will not serve every researcher's needs. The other is that we have lots and lots of data because we have routinely collected data, we have clinical data, we have social data. There's going to be lots of things in there that aren't reflected in, for example, the OMUP common data model now. So we might need to do extensions or revisions of those. So we want this, what we're doing is we're developing an information item middle layer so that we can be responsive and effectively create an efficient ability to put data into multiple different common data models. There's lots more to that. I'm happy to talk more with anybody who's interested in that, but it is something that we're, I believe that there's a lot of support for this, and we're probably going to be pushing it forward in some way. The other thing we're looking at is the state of the science of federated analysis. I know that in the genomic space, there's been some work on this already. And of course, with machine learning and other kinds of AI, there's been lots of focus on federated analysis as well. What we wanted to do, and this is going to be rolling out starting in the fall, a learning series on this with webinars that you'll be absolutely open to and invited to come along if it's of interest. But we want to think about, for example, what's actually possible to do now in federated analysis from a statistical perspective. So we know you absolutely can do very, very robust analysis with linear regression in federated systems. But there's actually work going on now in a CIHR funded project that's looking at difference in difference analysis. And there's some real evidence that's coming from that group that you can actually do that. And perhaps even with more robust results in a federated way, or at least with that kind of treating your data as unpooled in that sense. We also need to understand what researchers would have to do different to run their models in a federated environment. And by federated, I mean simply that the data are not all in one location. This could be technically enabled. It could be just that you have multiple different secure environments that you're working with. But we need to understand the researcher workflow and how we could support that if we're leaving data in a federated system. And then we also need to understand the permissions and structures and how we meet the 5 SAFE and other expectations if we want to move to that more technically enabled federated environment where it's a little bit perhaps more seamless and the researcher might have to do less hand-holding and moving things around in order to do really robust analysis. Short answer here is it seems like there's lots of possibilities to do absolutely research where we leave the data where they are, take the analysis to data, and still get very, very robust results without sacrificing anything in your actual outcomes and analysis. So watch for that. There's more coming there. The next is strengthening data use to improve equity and support Indigenous-led data sovereignty. I've already talked a little bit about the Indigenous data sovereignty space. So I'll just say here that we are committed to this. These principles that you see here, the CARE principles, come from the Global Indigenous Data Alliance. There's also, of course, OCAP principles, and the Métis and Inuit communities are coming forward with principles as well. So we want to do everything to be consistent with that. The other thing we're trying to work on in this space is more orientation for researchers. This will be another learning series starting this fall. And the idea that we really need to think differently and carefully about bias and equity in data. And the real key here is that, with the In Plain Sight report and other things that came out over the last few years, we understand that systems themselves have bias built into the way that they deliver services. And if that's the case, then that bias is going to be built into the data that we're using. And so we really need to think about whether we want to actually design that bias out because of the particular question we ask. In many cases, we probably don't want to do that because we're going to miss really important aspects of equity if we don't understand that the quote unquote bias in data, like selection bias and other things, in some sense could be driven by bias in those systems. So that's a really big topic of conversation, so I just flagged that here. Establishing and strengthening partnerships and providing leadership for evolving data practices is another goal. I'll just say quickly that we have helped in our network with HDR in Canada to open or close to open 2 data centers. That the Health Research Data Platform in Saskatchewan is now open, and the Prince Edward Island's Secure Island Data Repository, I think it's still one signature away from being open. There's also commitment to that. And we started working with the Yukon through their support unit to help think through their own data developments as well. We've also just about finalized the linkage of the CLSA, the Canadian Longitudinal Study on Aging, and the Canadian Partnership for Tomorrow's Health, all of those cohorts into our regional data centers, so it will be possible to request access to those data linked. I mean, those are incredible resources on their own, but now we will have the ability to link those and conduct multi-regional research, which would be the survey data plus the linked routinely collected data. Another thing to watch for is there's a pragmatic trials training program that's embedded in HDR in Canada. This is through the CIHR $250 million investment in both a trials platform through the Accelerating Clinical Trials Group based out of McMaster, but then also these training programs that are separate. And this one is specifically targeted around the use of routinely collected data for trials. It's going to be open to faculty, decision makers, postdocs, so people who might be leading trials, and then also highly qualified personnel who might be supporting trials, whether through methodological developments or that sort of thing. So there should be more information coming about this and some recruitment for this in the next few weeks. And I'd really love to see some people from BC participating in this. So I'm hoping you'll watch for that. And then the last objective, the 5th one, is ensuring ongoing public and community involvement. So we have a public advisory council chaired by Frank Gavin. It's a diverse members of the public from across the country. And they provide us advice on projects and priorities that we should be undertaking and how we can best communicate what we're doing with health data to broader members of the public who really have maybe not so much idea, but at least may have some interest, and we have a very strong commitment to that transparency about what we're doing. They meet 5 times per year, and we have those meetings always with simultaneous translation, was encouraging French participation in this, and then one time a year they meet in person. We worked with our public advisory council to do a bit of social license work related to use of health data. This was a pretty simple and small scale project, but it was meant to support the work of the expert advisory group. So this was funded by Public Health Agency. And it was just to look at what we already know, but then how members of the public in Canada respond to that kind of current information on that. And we found that lots of agreement that it's absolutely public wants us to be using these data for clinical care, for health services improvement, for health research. But agreement, at least full consensus, does start to diminish when we start talking about private company access and use and data about systemically marginalized populations, how we should be doing those. And it's clearly not within social license to sell data or to use purpose where there isn't public benefit. So there's strong agreement on things, some strong agreement on things, and then some middle ground. So there's lots more to do in this, and it kind of relates to that part of the health data charter where we say we really need to include the public in ongoing conversations. This is just a note that we had a health data for all of us. This is a public hybrid event that we had. If you're interested, Rachel Plachinsky gave a great talk about patient involvement and how that has changed some health data practices and health research practices. These are online and on the Health Data Research Network Canada YouTube channel. So very quickly, what's coming next? There's lots more that we need to do, as I've already identified, on collective efforts to support the Health Data Charter. Would love to have your input on how we go about creating that collaborative and collective space and the kinds of things that we should be doing. There are, as I said, going to be lots of webinars on the Data Access Support Hub, on federated analysis, on inclusion, diversity, equity, and accessibility, all sorts of things coming from HDR in Canada. There will be recruitment for the pragmatic trials training program, and we have a newsletter for signing up. So all in all, I think there's lots of energy and interest still around the Pan-Canadian health data strategy space, lots for all of us to be engaged in and doing. And I hope that some of this will spark some new ideas perhaps, and of course commitment that we'll all be working together over the next while to make all of this happen. So thanks for all of that. I'll stop my slide sharing now and look forward to any questions.
Thank you so much, Kim. You really managed to pack quite a lot in there, but I loved many of the points, and I'm quite surprised, but also very excited about how much progress you had made on the HDRN side. And especially, I'm very excited to hear that the Canadian Longitudinal Study on Aging and CanPath will be linked within the HDRN. So really great to hear all of that. I'll probably contact you about that at some point through the summer or the fall. But the other thing I wanted to say that after reading the last report of the advisory group and saw the data literacy, need for data literacy, that's kind of where the idea of having this data literacy webinar series got cemented. So thank you for inspiring us to do more in many of these areas. So we'll go through some of the questions that we have received online. The first one is Sky High implementation roadmap published?
No. So you're talking about the High implementation roadmap for the Pan-Canadian Health Data Strategy.
Yes, that's what I'm guessing that they had.
It is not, and it's still evolving. Like there's still so many conversations going on. It's there's active conversation between High and Health Canada and Public Health Agency, but no, there's nothing formally published about that. Although okay. I'm sure that people from High would be happy to come and give a talk about the current status if you wanted to arrange that at some point.
That's a great suggestion. Thank you. So I don't know if you know this, but given that you guys or the group was advising on what are the different aspects that should be considered for the Pan-Canadian Health Data Strategy. But do you know if there is any plan to see what other countries have done with respect to the health data system and sort of get inspiration from that instead of starting from scratch?
Yeah, I mean, that was for sure embedded throughout. We were paying a lot of attention, particularly things that were happening in the UK is one, but in the EU, actually more broadly, there's lots and lots of stuff going on there that it has been relevant a little bit in Australia. And then of course, there's an example of Finland. So all of those things did inform what we were thinking about and doing. And interestingly enough, the main person who supported the Secretariat and did a lot of the draft writing was Eric Sutherland, and he's now at the OECD as digital leader there. So we're keeping in touch with him because he's now got a really interesting international OECD type perspective on things. So yes, absolutely. All of that's very, very important.
Perfect. Thank you. There is another question about the learning health system and the role of AI in all of that and what kind of impact this would have on patients and healthcare providers. And I know that this sort of, there are some examples already of different health organizations using AI. I don't know if any of this was discussed during the advisory group meetings.
Well, for those who know this space, Mohammed Mamdani, who's one of the AI leaders in for within hospital applications of AI in Ontario, he was part of the expert advisory group. So some of that came in. It's too much to think about how we incorporate all of that. I also am increasingly thinking that we're going to have to not just think about AI and healthcare, but really sort of subdivide that into different applications, because you can think about how AI might help with actual coding. Maybe, instead of, we could think about AI reading charts and actually producing some draft coding for people. That's quite different from AI being used in the ICU like Mohammed and his colleagues are doing. to try to predict who might be having who's at risk of some kind of crisis within an ICU. And that's different again from using things in primary care to guide delivery of care, whatever. So there's just, we need to, I think, get a little bit more creative or explicit about where AI is, and then really think carefully about all of the biases that come from the potential for use of AI. We talk about AI as being a black box. I'm not sure that the black box is the problem, because we run the healthcare system on black boxes now, which are the human brain. The difference with AI is once things are in that black box, you're not talking about affecting 5 or 10 people, you're talking about affecting perhaps an entire population. So the scale of the implementation is what really matters. So that means that we have a responsibility to think through really, really carefully unintended consequences, bias of input data that might have affected AI, and so on. But some of the ways that we might use AI, operational planning of for operating room distribution in hospitals, is really, really far less challenging than other applications of AI. Sorry, it's a bit long-winded, but it's a really, really important space. And I think that we need to mature the conversation quite a lot.
Yeah, and I do see that, as you mentioned, like using it for operational improvements is already being started. It just, I think, balancing, I feel like this is the balancing act of allowing enough resources to work on this to save resources for later. And it's just sort of like this vicious cycle of do I have time now, but then it saves me time later. So another question is around provinces are at different stages of rolling out their EMR implementation. Here in Alberta, Connect Care, building on the Epic platform, is being rolled out as we speak across the province. Considering that most all provinces, territories have selected their EMR platforms, could you comment or already foresee any challenges with the implementation of the Pan-Canadian Health Data Strategy, or do you feel that the technical platform chosen are well positioned to connect across provinces, territories?
Yeah, it's such a
question.
Yeah, no, it's such an important question, because there's so many things to consider in all of that. So there is some work on the ways that we need to change procurement, and I know that provinces and territories have actually asked Canada Health Infoway to help with procurement, because the contracts we sign with vendors actually have some role in this. So we can have requirements that say you must make data available out the back end, or connect to FHIR, or all of those other things that, regardless of the technical platform, then we can actually impose some interoperability between and among different sources of data. So that's one thing, is that procurement part of it, where we get those into contracts and expectations of vendors upfront, is really important. There's another consideration, and so Alberta made I think quite a bold decision to go with a common clinical information system across the province within at least the acute care sector. So that can make things easier from one standpoint in that sector. It still needs to interoperate with other parts of the health system. So you still are going to have that interoperability. So we still need to think about requiring vendors to be able to interoperate, whether it's through FHIR standards or other technical standards and so on. The other thing I would say in all of this is really complicated. There's always going to be multiple technical systems involved. And I don't know that I would say that the solution to this is to go with a single vendor in all cases. Like, I applaud Alberta for what they're doing. Does that mean that we should use Epic across the country in every hospital? I'm not sure, because that changes a power dynamic between vendors and the health system. So actually, I think if we can get to more I think the more recent thinking about building stacks of IT enterprise and ensuring interoperability, then we're going to be good for the future. Then we still need to think about what we're going to do in this space we have now, and in the intervening time before all that interoperability is actually achieved.
Yeah, great answer. I'm just thinking of all the standardization among the different things. It's the greatest problem somebody
Hard.
has to solve. Yeah. I think this question, next question, is related to the HDR and how hard is it to access the data, and how long does it take for review before release is approved?
Yeah, so I'm going to answer the last part first. We're aiming right now for 6 months. I'm not sure that we are achieving that in all cases. So that's part of it. We are working on everything we can do to shorten every part of the process that we actually, whether in our individual data centers or HDR in Canada, have any control over. But many of our systems still rely on external governance processes that we only can massage and encourage so much. So that's one piece. What we're really, really focused on in this first right now is minimizing the time that research teams have to spend on it. So the elapsed time might be 6 months, but you're not going to have to spend a huge amount of time in that process. So I think the intent is for it should be much easier for you to make an application, because we can give you all the support services to know which provinces and territories can support your research, and then the single application form that you need to fill out. So it is still work for sure, but not nearly as much as it would have been in the absence of HDR in Canada. And then we're also thinking that as we develop our, what I described as our health information items, in many cases, what we hope to be able to deliver to people is data that's much closer to readiness for analysis. So while it might take you 6 months to get your data, we're hoping that it will take you less time than it would normally take to massage your data into readiness for actually running a model. So it's a reasonably complicated way that you need to think about the full life cycle of analysis to understand where we might be able to have an influence, but that's what we're focused on now.
The next question is around how can stakeholders outside of the organizations that you had mentioned can support the implementation of the health data charter, like maybe researchers, any of us on the call.
Yeah, I mean, I would love to hear anybody's, please follow up with me by email or whatever after if you want, but we'd love to hear ideas about how to do that. What we've been talking about within the expert advisory group members that are still really working together is finding a way, and it probably is going to start with something like a website or something, just for people to sign on to the principles of the charter and then find each other and start thinking about how we could craft some initiatives or get something going that helps push some of these ideas forward. Because you can see that there's, like, and as you said, Zhuja, there's so much to do. There's so many things that need to take place. And it's why we're really focused on trying to make sure that all of the activities that we want all the stakeholders involved in actually help push us in a similar direction. So we're not working at cross purposes. So there's more coming on that.
Thank you. So we have 3 more questions, quickly going through the last 2 minutes. There is a great list of recommendations from the Health Data Charter. Some principles will be contrary to each other when you are going down to the next level or under certain situations. Example is data privacy versus innovation industry access. What's your recommendations to the organizations with the data stewardship mandate to balance these requirements? Another great one.
Yeah, it's a great question. And I'll try to be a really simple answer here. This is part of the reason I think we need to involve the public, because there's a really big space between what is legally allowable. Obviously, we'll always work within what's legally allowable, but there's a space between that and what's socially acceptable. One of the ways that international and some of our provincial colleagues have tackled this is when private sector wants access to data, we give them access to analysis and answers rather than direct access to data. So that's one way to kind of create a little bit of well, more than a little bit, some guardrails and some services that support private sector needs without revealing the data to them.
To what extent is bilingual data language a challenge to an efficient federal system?
I don't think about that too much, because it's a reality of our federation. And I will also say that Quebec is actually doing some really, really interesting things, both in legislation and in some of the data support work that they're doing. So it is, it will cost some extra money because we do use simultaneous translation and we have a commitment to translating everything into French. But I think there's a huge advantage in learning from the different ways of thinking. It's like, and different ways of doing things and trying to bring that all together. So it's just reality in Canada, and it doesn't need to slow us down.
All right, last question. Are you looking to expand your partners? Universities and research institutes are custodians of large research data sets, yet are not well represented among the partners. What is the role of the principal investigator of these data sets?
It's a great question. And the way that we're thinking about that is actually we're developing what we're calling the Health Data Research Alliance, which would be similar. So CLSA and CanPath are our first members of that alliance. So this idea of there's lots of additional data that we need to pull in, and with organizations we want to work with that don't necessarily need to become part of Health Data Research Network Canada to do that, because you want to have your own ongoing identity and purpose and so on. But the Health Data Research Alliance will be a way to create that collective partnership where we can actually try to move that forward. So Long COVID Web is an example there. Some of the cancer data strategy work is part of that ambition as well. So I would love to hear from anybody who has data that they think that, or other ideas that they think that would fit into that Health Data Research Alliance space.
Thank you so much. We've really covered an excellent amount of topics, and I love to end on actually the answer that you just gave, because I do see researchers having a role in all of this, not just as users, but as contributors. So
absolutely,
I'm looking forward to people's, sort of comments and ideas stemming from this presentation. Thank you so much, Krim. This was just amazing learning. Even though I read the report, I've still learned more. So it's been really appreciated, your presentation. Thank you so much.
Thanks for the opportunity.
Thank you for all the attendees as well. Bye-bye.